Thank you very much. Nino, you are so precise on time, and give me 18 minutes for starting the discussion, and we will stop at 18 minutes. I'm going to present a real case we had a couple of months ago. We are talking, and I will write some questions for you about ICP insertion and so on. And I'm talking about ICP mainly in this case. He's a 40-year-old patient. He had a road traffic accident. He was found in outside the road, and we didn't have any information about the time of trauma. On the scene, he was in coma, as we defined the patient yesterday, because he wasn't able to open his eyes, no verbal response, and motor score was 2. Unfortunately, the patient was hypoxic, hypotense, hypothermic, because we don't know how long he stayed in outside the road in the crash car, and he had some bleeding from the scalp. He was intubated and transported to the nearest hospital, as in Italy we are used to do, and the advanced life support crew infused on the site 2 liters of crystalloid infusion. In the first hospital, he had a total body CT scan and that revealed a cerebral contusion, a small pneumothorax, and multiple fractures. He was transported to our hospital. He arrived in the hospital sedated with propofol. It's the most common drug used in Italy for sedation, and he was evaluated at the arrival. So an important message is when you got a patient, and we don't rely on the information we get from the scene or from the other hospital, we stop the infusion of the drugs and we visit the patient, and as you can see, the clinical situation did change so much from the scene to our hospital. Unfortunately, the blood pressure wasn't so high. He was tachycardic, and we started to infuse crystalloid, colloids, and we ordered some blood. He was mechanically ventilated. PO2 was 100, PCO2 was 35, and the temperature was low. The first exams we got were he was anemic, the number of platelets was low, 40,000, and the coagulation setting was pathological, as you see. This is the CT scan we got. We made also an angio-CT at the time. We are used to doing trauma, as Peteron said yesterday, also the angio-CT, and we had a bilateral frontal contusion. This is the first question for you. Do you believe that according to the Brain Trauma Foundation guidelines, there is an indication to insert an ICP device? I would like to know from you who is for the first option, very weak, the second, uncertain, third, strong, fourth, immediate. For the first one, nobody. For the second one, uncertain, nobody. For the third one, strong, nobody. Who is for the third one? Okay. A couple of strong, and who would like to insert immediately? Okay, many of you would like to insert immediately the ICP. Yesterday we discussed this point, and we have got, after this question, would you like to insert an ICP immediately? And for example, Robert Stevens, the answer was yes, I go straight to the OR. Some American colleagues would like to insert in the emergency department. In my institution, we decide to wait because we have to balance, as we discussed yesterday, about between benefit of having the information and the risk. If you take a look back to the patient was hypotense, and mainly the number of the platelet was very low, 40,000, and the coagulation was pathological. So we decide to solve this problem before getting the information of the imbalance on the volume inside the skull of the patient. And I think this is a crucial point, because sometimes we are in a hurry, we are excited, we want to put the catheter in, and if you want to reduce the number of complications, it's better to be wise instead to be aggressive sometimes. And for example, with Nino we collect more than 1,000 patients, TBI.
Almost 2,000.
No, now are almost 2,000, but looking at the patient with ICP, we are talking about 1,000 patients, and the number of complications in our series I'm talking about the hematoma around the catheter, and we classify the hematoma as any visible blood around the tip of the catheter, around the path of the catheter. Everything, the incidence is lower than 1%. So it means that you take care of this problem, the complications are very low.
Why did you sedate the patient if he has such a severe coma? I don't understand. Is it to induce hypotension? Sedated with propofol. Why did you do that?
Because it's a standard way to reduce the metabolic consumption.
Oh.
And even if the patient is comatose, he can fight the ventilator. He's not sedated, he can have a high arterial pressure. So yesterday, 2 days ago, we discussed about autoregulation and so on. So it's a standard practice to sedate the patient because we don't want to have only the negative effect, as you said, the hypotension, but we are looking for more positive effect. That means reduction of the consumption.
Abolition of coughing.
Also coughing.
But why would the patient cough?
Because he has a tube.
What? No,
Yes.
Our patients don't cough.
Okay.
I don't
Be-
know
be-
what kind of tube you have.
Because
During transport, Jean-Louis,
They don't cough,
be practical.
especially when they are very common.
Jean-Louis, maybe they sedate the patient without saying it to you, with other drugs. So we have this clinical situation, and in this clinical picture we decide to wait a while for solving the problem. And the question for you, do you have a question, Fabio?
Yes.
Please.
As your hemoglobin levels is 6 grams deciliters, there is another issue in the treatment of this patient, which is not only the brain, is acute bleeding.
Yeah.
And in this case, this patient is unstable. Maybe the surgical with the damage control could be one solution. So there will be 2 reasons to go to the OR. Not directly agree with you, but not to delay too much.
Thank you, Fabio. For the second question, we had a total body CT scan in this patient with contrast. We didn't have any bleeding. In other area, maybe in the abdomen, we didn't have it. We had a small pneumothorax that didn't change between the 2 hospitals, and we did decide not to insert a drainage at that time, that was very small. And so we are looking also at bleeding because the hemoglobin is too low, and we thought at that time that the bleeding was due to the scalp lesion because the patient was found after hours. And for the first question, you said it takes half an hour for go to the OR, you have time to solve the problem, and is what we did. We transfuse the patient and we start to work on the coagulopathy, give him plasma. But the main message is don't be in a hurry for having the information when your patient is not perfectly controlled. So you need to have hemoglobin solution and infused blood. You need to have plasma in this patient. And when I have a normal lab parameters, I go to the OR. So you have to, please, I think there is Robert, yeah.
Giuseppe, you've done an excellent job of simulating the real life clinical experience, which is when the information about our patients is often limited and we have to work with assumptions. But I think in this particular case, I would be interested to know a little bit more about the patient and his history. I mean, you mentioned that he was 48 years old, or he is 48 years old. But does he have any significant past medical history? Does he have, for example, a history of cirrhosis, which may account for this coagulopathy?
As you probably seen in your real life, the patient was found. We tried to contact, if he was comatose, he wasn't able to say anything. And we did contact the family, but it takes more than this stage for having the family in the hospital. It takes a couple of hours having the family in our hospital having this kind of information. So if the patient is usually older than 38 years old, and we are used to take care of very old patients in the last few years, this kind of comorbidity is very frequent. In this case, I can say to you that he didn't have any comorbidity, but we discovered afterwards.
And
Please, Peter.
we'll try to focus on monitoring as well.
Yeah.
I mean, yeah. To
two, I think, important points. Number one, the Glasgow Coma Scale is meaningless if the patient is hypotensive. So when it's originally defined, you had to have a normotensive individual. So
and without propofol.
Oh yes, and without
Absolutely.
But he gave the propofol. He wanted to provide some fat.
But we did stop it.
It's for nutritional support.
It's nutritional support, immediate nutritional support.
No.
But so in a hypotensive patient, the Glasgow Coma Scale is not valuable.
Yeah.
If you are hypertensive and a fixed and dilated pupil, then the outcome usually is very, very bad. The second point is coagulopathy is a contraindication to placement of an intracranial pressure monitor or any intracranial device.
Yeah.
So if I was called it as a surgeon, and in our hospital, we might well be there at the time, I would say to Giuseppe, you are crazy.
Yeah.
You are nuts. I will never do this. Fix the coagulopathy and then place it.
Yeah.
And so, but as is important, all of this is very dynamic. It's happening in real time. It's not that you're doing one thing. It's all happening at the same time.
I think the 2 points are very important. The second one is the coagulopathy, and the first one is that we need to have a reliable information of the patient. And what we demonstrated with the Neuralink connection with Nino, that about 10% of the time we are doing not a correct evaluation of the patient in the early phase because of sedation, paralyzation in some patients. They bring you the patient with infusion of muscle paralyzer, and sometimes we are not so good in opening the window and visiting the patient, even if we stop the infusion and we think we are able to have a reliable exam. The other point is that we need the information when the patient have a normal arterial pressure and a normal oxygenation. If we can go ahead, I have a question for you, from our friend surgeon. Is the coagulopathy due to the bleeding, due to the intracranial lesion? He had a bilateral frontal contusion, to both of them. What is your opinion, Peter?
So, in a child, yes, the blood loss from the scalp.
Can you hear?
Yeah, Peter, come here.
In a child, yes, the blood loss from the scalp can lead to profound anemia and hypertension and coagulopathy. Less so in an adult, although clearly a lot of blood can be lost from the scalp. It does depend a little bit on how long he's been lying there. More likely than not, his coagulopathy is also related to the intracranial lesion, because there's a lot of coagulopathy that results from severe brain injury, the thromboplastin release and so on. But in a way, for me as a surgeon, I don't care where it's from. I care that it's corrected.
Okay, perfect. So we can skip some slides because we thought that was due to the bleeding, but also, as you can see from the impact database, the low platelets are present in 7% of the population, and the elongated coagulation times is present in a third of the patient at admission. So it's very common, and the number of platelets and the elongated PT times, if you look at the lower line, that means probability of mortality. Below 100, there is an increase of probability of mortality, and with a longer time, there is an increase of probability of mortality. But our thought was also that the coagulopathy comes from the brain, because, as you said, it's the richest tissue of thromboplastin. And if you look, for example, at thrombin, antithrombin complex in the first hour comes from the brain directly. So, and we can skip some slides because we are going to focus on neuromonitoring. And after 4 hours, the patient was no more hypotense. The heart rate was 110, now is 85. He was mechanically ventilated, and we keep the PCO2 at 35. We transfuse the patient. We have a normal hemoglobin. We didn't reach a normal number of platelets, and we decide to wait. I will answer to this question. We decide to wait because we wanted to infuse platelet, and we did a new CT scan. The new CT scan didn't present any change, but we were able to infuse in the platelet going around 1,000. and we decide to insert an ACP device. What kind of ACP device do you like to have? Peter is here. Do you like to have a subdural catheter or a lumbar drainage, because you love lumbar drainage? Or an intraparenchymal device, a ventriculostomy, Peter?
I'm a 4 in the first instance.
Okay. We insert a ventricular catheter at that time. We set also a CBF probe and a jugular saturation afterwards. And the first value was ICP 15. The first CBF was 20, and the jugular saturation was 60. We got some information. I know that Nino the first day said that we are not so good in understanding the difference in the waveform we got from the monitoring system, but I think we can have some rough information. And Peter, I challenge you, what is this patient had 20 millimeters of mercury of ICP. What pattern do you think we will have?
Maybe the answer is wrong.
A. If you think about the physiology, when you have A, means that every arrival of the blood inside the skull, 15 milliliters, produce no changes in pressure. If you are above the flexion point and the system is closed, you don't have any fistula, you don't have any problem in the system is closed, probably, and I say probably, you will have the second pattern. So we use this information as a quality information when we have a catheter inside, because if we have 30 millimeters of mercury in this pattern, probably there is a hole, there is a fistula, there is something, and the regional cerebral flow was 20. We started to talk about the first day, 17 minutes, and do you think it's okay for this patient, Peter? It's okay. We thought...
Before recalibration, because the Hemodex value changes enormously every time it recalibrates.
We calibrate, the system calibrates every half an hour, and this is a stable number after a couple of calibration. And
no, it's not.
Because the temperature did change, but in this case the temperature was 37 and remained 37 for days, because we are in Monza.
And this is white matter still.
Yes, absolutely. We discussed in the first day, the catheter is white matter, and in Monza, fortunately, you will not have a fever. So the temperature will not change. We are using infusion for don't having fever. Talking about treatment, a couple of hours later, we have 2 minutes, I think, ICP went up 25 millimeters. I would like to solve this problem because we had an increase in ICP. We had to increase also the oxygen to the patient because we had some hypoxia. And nothing else did change. The pressure was the same. How do you treat this ICP? This is the last question. Who would like to use surgery? We had a bilateral frontal contusion, osmotic hyperventilation, or repeated CT scan, and search for the cause of the increase of ICP, because at the beginning the ICP was low.
Did the ICP settle when you improved the oxygenation?
Didn't change.
Randomized to Eurotherm study, I would say.
No, it's wrong. Stop, it's wrong, because you didn't start any treatment. So it's wrong to randomize the patient because you didn't start at this stage any treatment. You didn't. No, it's a question. Surgery, osmotic hyperventilation, and you put 5 randomization. It's wrong, because you didn't treat...
I would disagree, because we'll never make any progress in the management of head injury unless...
You are making damage, because...
No, we need to do prospective randomized trials. Just, there's no evidence for osmotic therapy, no evidence for hyperventilation.
Yes, I know there is no evidence, but we have a treatment that could impact coagulation, and at this stage my advice is to search the cause and start the treatment. And the cause...
Unlicensed experiments.
Okay, this patient had a pneumothorax that was impacting the oxygenation, and the treatment was the drainage, as you see, and not hypothermia. Thank you very much. 20 minutes. I can go ahead for an hour, but...